Laura, thank you so much for joining us on the patient story. Really appreciate your time.
You're welcome.
And you have such an incredible, and I say this, but I really do mean it. You've had such an incredible story to share with people, and I know it's been ongoing. And so, really excited to be able to put this resource out there for folks who are looking for these answers. And so, why don't we start with, you said it's been about 9 years or so, but you still remember a lot from the beginning. Can you describe when you knew something was wrong?
Well, in my case, I really had, um, I was diagnosed with stage 4 kidney cancer by way of a brain tumor, which I don't know how often that happens, but for me, what that meant is my main primary symptoms were headaches. And for several weeks, many weeks, I managed the headaches with ibuprofen. I was working as a full-time attorney in a corporate position, and I was busy. My immediate boss was on her own leave of absence, and so I had stepped into her shoes for about 12 weeks, or not exactly her shoes, but in a very higher level supporting role. So I was really busy and managed headaches with ibuprofen and caffeine. So that was my primary symptom, but those headaches became increasingly severe over many weeks until they really started to affect my sleep. I had a small child at the time. He's now 16, but he was under 7 years old at the time this was starting. So there was bedtime reading stories and, soothing him to sleep, and those kinds of things started to become more difficult for me. I couldn't keep my eyes open. My headache would keep me from engaging fully with him. And so that's when I really started noticing it more. And then I had a couple of episodes of very extreme headaches that certainly were warning signs, but they would pass. And so it was easy, I guess, or convenient for me to overlook them to some degree. And so that was the primary symptom I had. But they were intermittent; they would come and go, and then they got increasingly worse. And then I had a couple of very distinctly severe headache episodes.
And those, I imagine, were what prompted you to, go to urgent care. You said, this is obviously something's not right. I can't handle this with ibuprofen anymore.
Well, yeah, I mean, I actually had scheduled an appointment with my primary care doc to say, let's have a physical and talk about the headaches. But before I could get to her, I was out on a winter day with my husband and my son after a big snowstorm, and we'd gone to go get ice or salt for the sidewalks. And we were actually in the store shopping when I had an episode of a very significant headache. Made me sit down. It made me really concerned. I didn't know what was happening. I didn't lose consciousness, but it was not right. And I just looked at my husband and I said, "Do you think I'm having an aneurysm?" And he said, "Well, I don't know. Let's go to urgent care," which happened to be across the street basically from where we were. Mm-hmm. And that's how it all started. I got into urgent care like within 20 minutes of having been shopping with this headache, and saw an urgent care physician. They triaged me immediately to the front of the line. So obviously they thought there was something going on that I didn't recognize. And then from there, the urgent care doc spent a lot of time with me, checking my reflexes, looking in my eyes, things like that. And then she just sort of surprised me and said, "Listen, I want you to go get an MRI so that we can rule anything serious out, and we'll probably be back here to talk about a migraine condition," which I've never had. So that's kind of how it happened. It was really sort of a episodic situation where I was out and happened to be near an urgent care, and that's what happened. And so we went for the MRI, and we took our son to my sister's, dropped him off, thinking we'll be back to pick him up shortly. I went for the MRI. By the time I got out of the tube, the MRI tube, the doctor who I'd seen at the other clinic was on the phone and waiting for me. And I was like, okay, well, let's see what she has to say. And she's the one who I had just met that day. The urgent care doc said, listen, there's something in your brain and it needs to come out. And a neurosurgeon has already seen your film while you were in the tube, and he is on his way to meet you at the hospital.
Wow.
So that was how I found out there was something going on that could be addressed immediately.
Wow. Wow. My gosh. No wonder you remember everything so clearly.
Yeah, it was like watching a movie.
It really does. I mean, that's so dramatic. I mean, to just go from, like you said, shopping to then find yourself urgent care and then having a doctor tell you that you need to go to surgery essentially right away. Can you describe in that moment how you were able to, I mean, did you process it at the time, or were you like, okay, let's just take these steps to what I need to do and take care of business?
Well, yeah, I mean, I think there was this sort of on autopilot, I'm being told what to do. The doctor was on the phone with me, and she said that they're going to come and escort you to ER now. And I was like, who's they? She's like, are you dressed? Yes. They're going to come and escort you to ER. And I was like, okay, where am I going to find them? Oh, they'll find you. And I was like, okay. And at this point, I've got a glass door between me and my husband, and he's looking in at me on the phone, and I'm looking at him, hearing this information. And it was just like surreal. There was just really I didn't have a context for it. And so I just followed the directions. And she said, can you do this? Can you go with them to ER? And so that's what happened. I got off the phone. These people showed up from ER. They flanked me, and they literally walked me to a bed in the ER, put me in the bed, and they hooked me up to an IV, which I wasn't exactly sure what it was, but what I was told was I had so much swelling in my brain from whatever this was that they needed to control the swelling. And that's what the IV was for, and that's why they wanted to get me to the emergency room and be treated with steroid, I guess, a very powerful brain that they use for brain tumors, which I now know, to contain the swelling. And that's what happened. And I ended up in bed with an IV and I was waiting for the neurosurgeon on call to come and see me to describe what more was going to happen.
And can you summarize what that message was when you met the neurosurgeon?
Well, he was very calm and kind, and was very circumspect about what he could see in the imaging, but he said it was a brain tumor and it needed to come out, and that we wouldn't know what it was until they could do the pathology on it. He was not giving me any statistics or data or what he thought it could be. He was trying his best to keep things as neutral as possible until we knew more. But it was clearly, by then we knew it was very serious. It was described as about a golf ball size mass, and pretty much all the amount of swelling in my head put me at high risk for having a stroke, passing out, becoming unconscious, or a variety of other sort of neurological complications. And that was why I needed to be on the IV medication in the ER. And he said he needed to do surgery to remove it as soon as possible, but he couldn't do the surgery until the brain swelling came down, which meant I needed to be on these powerful steroids for about 2 days before he could actually do the surgery.
Okay, yeah, I see that on your timeline. So 2 days later, this brain surgery happens to remove the tumor. And then it's not for another couple days when you get the pathology results back. And can you share with us what you learned that day?
Yeah, well, initially, the initial pathology that they did looked like it was good. Like there was no cancer cells in the initial pathology. So when a couple days later, a different doctor who I'd never met approached me to say they needed to do more imaging of my body, I was confused and I didn't know why, since I had already been told there was nothing else, there was no other problem. It was a benign, what they call a meningioma. But then the plan changed. And so I was confused and wasn't being told why more tests were being ordered. But I did the test, and yet a different doctor came in to talk to me after those tests were completed, to tell me, and by then my husband was with me, that there was a mass in my kidney that it was diagnosed as renal cell carcinoma by the pathology, and they confirmed that by finding the mass in my left kidney.
Wow. Okay. And that's a lot, obviously, for anyone to take in at that moment. Did they explain what that meant? I mean, this is like cancer medical jargon, right? How did they explain what this was?
Well, this is part of what I think that patients who encounter the system in this way, are at a disadvantage because no, this person was not an oncologist. She was like a general hospital person coming to tell me my test results. And then the next step was to engage the oncology specialist, within the next few hours, who then arrived at my hospital room to talk to me more about what these things meant. But clearly, being told I had a softball-sized tumor mass in my left kidney that was related to the brain tumor they just removed was a pretty obvious message that this was a stage 4 situation.
Right. Okay. And so you were able to talk to oncology specialists a few hours later, I'm hearing. Can you describe those
Yeah.
conversations?
Well, the discussion was mostly about potential treatment. Well, the first part of the discussion was the need to surgically remove the tumor in my kidney, which necessitated conversations about, who was going to do that and when and where. And then the rest of the conversation really was about, likely treatment options. And this is the first time I heard the name of at least one type of drug at the time that seemed to be a relatively recent drug that they were using to treat advanced kidney cancer in this type of situation, which I didn't really understand specifically, other than there seemed to be some hope that my situation could be controlled at some point with some kind of a treatment method, a chemical treatment method on top of surgery and radiation that seemed to be part of the picture at the time.
Okay. So you are told that it most likely this started in the kidney and then had spread elsewhere?
Well, they knew by the pathology that it was kidney cancer by then, and they knew that it was connected to the brain tumor because they had enough time to study all the pathologies by then.
Okay. Laura, I know, again, this is, something that you remember pretty clearly. How were you able to, and that, I mean, your husband's with you, I imagine. How are you able to process? Do you remember that moment when it hit you? Okay, there's stage 4 kidney cancer.
Well, the first thing I did was I ordered the first doctor to get out of my room. So I wasn't very good. I said, I don't know. I don't know who you are. I want to talk to my doctor.
Yeah.
And I don't trust you because that's not what they told me before. So it was a pretty irrational, perhaps emotional then eventually when I was surrounded by my family, including my husband, to get the information from the oncologist, fortunately, I had people around me who could also ask questions about what did some of these things mean. And at that point, it really was just sort of getting to the next step for me, which was having the surgery to remove the kidney tumor and my kidney, which happened about 2 weeks later.
Before we move on to that part, I'm just curious. It's tough enough to be sharing a diagnosis, period. And then I imagine even harder when it just feels like it's stage 4. How were you able to, talk to your loved ones about what you had just learned? Was it difficult, or did you sort of outsource that to your husband, or?
Well, I think what happened is, I've got a lot of experience separating my emotions from my logic. So I think some of those sort of skills kicked in. I was able to articulate, at least to my parents, when I had to call them and tell them what was going on and ask them to come to the hospital room to be present with the oncology visit. So I handled that. And then in the midst of all the information that was being told to me, I listened, I think, more than I talked. And other than that, I think I was just trying to process the information. I think in retrospect, I just was probably in shock. And so I think I went into some kind of a mode where, at some point I felt like it was too much information. I didn't really understand it, and I didn't really know exactly what to do with it. But my husband was there, and so he was very supportive.
Yeah, and you're bringing up a great point, which is, and I've heard this from many, many people. It's so helpful to have other people, whomever you trust, to really take on that responsibility, because in those moments there's so much coming at you, right? I mean, is there any more guidance you have for people on how to better sort of handle everything? Have someone else with you?
Yeah, I mean, everybody I think is different, but it is to receive information like that in the way I did, which was relatively out of the blue. I ended up in ER with this problem, so I didn't even know that there could be this issue kind of lurking. So I don't, I think that the best thing perhaps to do is to try and stay as calm as you can, because in those initial moments that you're receiving this information, even those professionals around you may not have all the answers. In fact, they usually don't. It's a triage situation. It's this type of thing was really kind of an emergency setting. So I think, to somehow recall, or at least try to realize that there's more information to come, and that you will have time to decipher it on your own terms. It's a barrage of information initially, and that information can change, and it can be nuanced. And the next people you talk to, the next set of doctors you talk to, will help you put it in perspective more than probably that first day you hear anything.
That's really well put. And which hospital were you at this point?
I was at North Memorial for that first brain surgery and the diagnosis.
Okay. Was it is that a large hospital? Is it a teaching institution, or?
It was, no, it's not a teaching. Well, now I can remember, I didn't even think it's called North Memorial anymore. It's not a teaching hospital. It's a community hospital. It was the one that the urgent care doc sent us to because of our insurance. And so that's how we wound up there.
Did you end up switching or trying to get any sort of other opinions, or is this not really a situation? This is just like a triage, let's go.
Well, that's a good question because I think, in my case, because of where I was at the time of diagnosis, they were affiliated with something that was called at the time the Humphrey Cancer Center. And so when they sent an oncologist to my room to discuss it with us, he came from that practice. And so in a way, things were happening they were going automatically on this track. And so I started with that oncologist who then orchestrated my kidney surgery. And then he orchestrated and helped set up and procure the services to have the post-brain surgery radiation that I needed. So he was the oncologist who I started with because he was the one who came to my hospital bed because of what hospital I was at. Eventually, however, within the first few months of that whole episode, I started looking for more information, partly because my husband was looking for information, and he was really kind of paddling the boat at that point about gathering information about the diagnosis and about the various kinds of treatments that might be available beyond what we'd already been told. And we really just sort of discovered that we felt like we needed more information and perhaps a different oncologist. So we went for a second opinion to Mayo Clinic, because if you live in Minnesota, you might know, Mayo Clinic has a very big, well-known presence. And so we did that, and we didn't really feel like there was much more information that we thought we would get. We really didn't find much more information there. And so I was going to stay put with the oncologist I had already met. And then I happened to read a book about being a cancer patient. It was called The Crazy Sexy Cancer Tips. It was a book that my husband bought for me. And because I didn't really want to be doing any reading or research, but he thought maybe this was a book I could handle. And I did. I started reading it, and I came across a chapter that had bullet points, kind of like a checklist. And one of the questions on the checklist was, make sure that your oncologist specializes in your kind of cancer. And I thought, wow, that just hit me like a brick, right? I didn't ask. I hadn't asked the question. And so that really led me to my next set of questions that woke me up, and we started asking more questions. And in fact, this oncologist who I liked fine, this was not his specialty area. And then all of a sudden, we had a mission, and we found a doctor, an oncologist here locally, who does specialize in renal cell carcinoma. And so I switched my care to him. And then has been handling my care pretty much ever since, with the exception of a few years when he moved out of state and then he returned. And so I'm still with him.
Okay, that's great that you're able to find a specialist, and that's really great tip, actually. Is there anything else that, through your experience up until this point, you feel is important that people should ask or know?
Well, I think, sometimes it's hard for patients to be assertive, because I feel like oftentimes we've learned or been socialized to feel or expect that the doctor is the person who has all the answers. And while they certainly, I think, have more answers than I would ever have, I think I learned very quickly that for me, being very direct and being like a collaborator in my own treatment process was a very important thing for me to be aware of, which really kind of started very quickly for me. And I'll tell you why, which is still kind of in this early phase, right, where I went to see this third opinion doctor, who I'm still with, and we had been asking about a particular type of treatment for kidney cancer, which is called IL-2, or high dose interleukin. And this is now 9 years ago, right? And so there were fewer options available for treatment then than there are today. And IL-2 was one of them. And we had been asking questions about IL-2 to our previous two oncologists, one at Mayo and the one from Humphrey. And they were like, well, yeah, but you can't get it around here. You'd have to travel to find it. You'd be a great candidate for it, but you really can't get it here. By the time I got to my third opinion, which was roughly April, I was diagnosed in February of 2011, and by April, I was already like on to my third opinion. And when we sat with that doctor and laid out all the imaging and everything that was going on, he said, well, my first recommendation for you would be to try the IL-2. And we said, well, great. Where do we get it? And he said, on the 6th floor of the University of Minnesota Hospital. And that was a very early and fortuitous wake-up call, both from the standpoint that I was able to take the treatment, which I actually responded to, but also a real wake-up call that despite how knowledgeable these professionals may be, some of them might have a blind side. They might not be as up-to-date or current on the various treatments available for your particular disease, or even the new developments that are coming down through the trial study process. So I learned really early, because of that particular experience, being told this particular treatment was not available to me when it actually was.
Wow. And so with that happening so early, I imagine you took that through today, where you've,
Yes.
yeah. Okay. That's really helpful to hear, actually. So now moving forward, and I'm glad you were able to go to that 6th floor and get that treatment you responded to. Without getting into that specific treatment yet, I know that it says here you had a couple surgeries up until that point already. With the removal of your left kidney, adrenal gland, the kidney tumor, can you describe just the prep and what you remember from that day and from waking up and recovering?
From the kidney surgery?
Right, yeah.
Well, so by then, let's see, it would have been a couple of weeks after the initial diagnosis. So I lived with kind of the fear already for a little while, and I was, I think, still really in a state of shock. I think by the time I was in that setting to have the kidney removed, I had a very good surgeon. I was able to, double check it with my own primary care doctor. Is this the doctor that you know? Are you familiar with? Yes. So I felt okay about where I was and who was doing the surgery, which is very important. That compassionate care is a big factor in your favor if you have it. But I was really immensely distressed. I remember the surgery itself went fine. There were no surprises that they found when they went in to take out the tumor and the organs. So that was good. So the result was good. But I remember being in an incredible confusion about what happens next. Now what's going to happen? I still needed to have what's called a focused radiation treatment to the brain tumor cavity, which is pretty standard, or at least it has been for me. After you have a brain tumor removed, at least with renal cell carcinoma, they often and probably standardly applied high dose radiation to the brain tumor site to try and kill off any residual microscopic cancer cells. So I knew that was the next thing, even after the kidney surgery. So I had another thing to have to look forward to that I'd never heard of before. So I think I was really sort of still in a lot of shock and disbelief and confusion. And we were really just following our instincts at that point. And all I could do was pull myself together as best as I could, because I had a 7-year-old child at home to have to try to explain things to in a way that were age appropriate for him.
Actually,
so I would say for me, that was probably a big part of my motivation to pull myself together.
right. Your child, you're 7 years old at the time. Actually, it brings up a great question, and we ask this to many parents who've had to decide how to share that news. How did you break the news to your 7-year-old in what you describe as age appropriate way?
Well, kids know a lot more than we think they do. I guess is the first thing I'll say. And it's important to remember that, I think, because our view was he had already lived with me and knew that I was having headaches. And then he knew I had a surgery because they found something in my brain that was causing those headaches. And then once the diagnosis came, there was more information that we had to put together for him. And so we had already concluded we needed to be as honest as we could with him so that he could understand that we're not hiding anything from him, but without telling him too much. And so what I think I remember we did, while I was in the hospital having the surgery for my kidney, I believe that was the first time I'd spoken with a social worker who came to visit me in my room. And so there were some resources that I think I got from her, at least to get my mind thinking about how do you talk to such a young child about something like this. So that was one thing. And then I was the one who actually, I decided it was important for me to talk to him myself. We were both me and my husband were there, but I was the one talking to him. And all I could really do was, explain that, this is what has already happened with the brain tumor. And now, because of the brain tumor, they found something else. And now I have to have that taken out. So that was a conversation, right? And he knew pretty much right away that you only have 2 kidneys, right? And so we had to talk about that. And we got his body book out, and we talked about how anatomy works. I'm not a doctor, but I know enough to explain that people can live with one kidney. And so it was sort of a progressive conversation. By the time we had the diagnosis in hand, it was a matter of adding to that by saying, now that they took this out, what they're telling me is it's something called kidney cancer. And he seemed to have already somehow been aware of what cancer, at least the word. I don't think he had any idea of what it meant at any sophisticated level, but he knew that it wasn't good. And so I tried to put it into perspective, and I said, listen, they took it out, it's gone, and I have very good doctors who are helping me get better. And his very first question after I said that to him, he looked me straight in the face, and he said, are you going to die? And of course, I don't know why I wasn't ready for that. I should have been, because that's all the kid wants to know, really. And, I said, listen, I said, and it was true. I said, nobody has told me that I'm going to die. And I said, as far as I know, I'm going to be okay. And I kind of left a bit of a hole there, right? Because he could have interpreted it more than one way. but I waited for him to see if he had more questions. I was looking for him at that point to drive more details if he wanted them. And he didn't at that point. He seemed to be satisfied with that information. We told him that we would let him know if anything changed or if he needed to have more information. As soon as we knew what was going on, we would let him know. And that was pretty much the first conversation we had with him about the diagnosis. And he had just turned 7 years old.
Okay. Wow. Well, that sounds like it went as well as it could have. He seemed to be satisfied, and you were as upfront as you could be without maybe overwhelming him. Speaking of which, there are a lot of other things I'm sure you were thinking of. Now, looking at your timeline, it's like, okay, I can see everything that happened. But in that first part of the experience, of the diagnosis, of the treatment, were you aware of how long this was going to, continue in terms of this is going to be ongoing treatment? Did you think about work, or was it like, I'm temporarily going to stop work? I mean, how are you thinking about life at this point?
For me, I think I was like kind of in a form of denial, right? I kept working. My capacity was not affected at all from the standpoint of my mental capacities. I worked from home for a little while after I recovered from the surgeries and went back to work.
Wow.
And so for me, work was a good way to distract what was going on and to maintain the normalcy. So I was very fortunate to be able to do that. And at the time, I had some very supportive coworkers, and I had a supportive workplace. So that was, I think, an example of how I dealt with it through trying my best to deny that it was really affecting me.
When did that change?
Well, that really only changed relatively recently. I changed jobs a couple times after that. And eventually, for a variety of reasons, I ended up sort of on my own, and I established my own practice about, almost 2 years ago. And it was in that sort of time frame that I had a brain tumor. I've had many, many brain tumors at this point, which are treated either by radiation or brain surgery. I've had full craniotomies to remove brain tumors, and I think about 15 brain tumors altogether by now, which when they're small enough, they will treat them.
Oh, Laura, you've cut out. Can you?
Ongoing strategy to contain them, kind of like whack-a-mole.
Laura, I'm sorry. You had actually it kind of froze for a second there. You said you'd had 15 brain tumors at this point, and when they're small enough, how do they treat them with the gamma ray?
Yes, if it's a small enough tumor, at least with kidney cancer, they use, for me, the gamma knife, which is a high dose radiation tool, and it's a whole process.
Can you describe it? Can you describe the gamma knife process in detail?
Yeah, so in Minnesota here, they offer it at 2 places. One of them is at the University of Minnesota Hospital, and one of them is down in Mayo Clinic. I still think that they're the only 2 that offer it. But basically, gamma knife, if you think, the way they described it to me the first time is, the idea behind the gamma knife is applying a high dose radiation to a small point. But in order to get all that high dose radiation into a focal, rather than spread around your whole head, in my case, is they have I'm not going to probably remember what it's called, that the delivery process is it's like a few hours, it takes a few hours, excuse me. You go into the hospital, they do MRIs again that morning of your treatment to make sure that, you know, they can plan to the appropriate levels of radiation. And then they feed it into a large, huge computer that then controls the radiation mechanism, which is basically, you know, first they have to put a frame on your head. Okay, so they put a metal frame, they bolt a metal frame to your head, like 2 here with 2 bolts here and 2 bolts in the back. So you have like a frame around your head. And then they use the frame to actually bolt you into the radiation machine so you don't move. So that is something different than other kinds of radiation tools that you might hear about, which include CyberKnife, for example, is very similar, but they don't bolt your head down. And the theory is that Gamma knives can be more precise because they bolt your head actually into the machine with that frame.
Wow.
And then the actual radiation tool that they use, I always describe it as they put you on a bed, right, on a bed where you're going to lay for the radiation procedure. They bolt you into the machine, and then they kind of back you into like a big salad bowl. I call it a salad bowl because it's like, you know, they're backing you into a dome. And the dome, inside the dome, is filled with like hundreds of little tiles. It looks like a mosaic. And in each one of those tiles comes a low dose level beam of radiation. And they describe it like, if you think about a bicycle wheel, it has all those spokes that like lead to the center of the hub of the middle of the wheel. And that's kind of like, if you think about what the Gamma knife is doing, all those low dose rays are working to focus into one place for the delivery of the high impact radiation. And that high beam is what they're all focusing into. Therefore, they can deliver a much, much higher dose of radiation to a very small area and not sacrifice the brain tissue, the rest of the brain tissue that those low dose waves are going through to get there.
Gotcha. Oh, gotcha. Yeah, that you, thank you. You said it, made it perfectly clear. No medical jargon there, so that was great. And I know you've gone through the Gamma knife many times. How long are you in the machine? And sort of any guidance in terms of how to get through that process, and then were there side effects after?
Well, the most difficult part of that process for me, and probably for a lot of people, is having the frame bolted to your head. The neurosurgeon, the whole process requires the radiation oncologist, a neurosurgeon, and a physiologist. The neurosurgeon is there to put the frame on your head, which requires, you know, large Novocaine doses to be applied to your head and into your nerves that run at the base of your skull. So that's the least pleasant part of it. It doesn't take very long, but that's the first step, is getting that frame bolted to your head. I have been able to work with the nursing staff where I have this done here at the University of Minnesota Hospital. And unfortunately, or fortunately, I guess, I've gotten to know them all really well over the years, you know. So we kind of know, for me, you know, I get there, you know, they put me in bed, I know what's coming now, but part of what helps me is they will give me maybe a small amount of Ativan to control the distress if I'm having that, or Vicodin even to control the pain, if there is any residual from where they bolted the frame to my head. So after that, you're really just waiting around for your turn in the Gamma knife room. And it really depends on how big of a tumor they're treating, as far as how long it takes. In my case, most of my tumors, the active tumors that we've treated, are pretty small. They're, you know, usually about a pea size or maybe a little bigger. And if you're only treating one, it could be like as few as 15 minutes active time with the gamma running. And so while you're laying there on the table getting the gamma knife, you don't hear anything. It's quiet. They can play music for you. They'll pipe the music in. For example, you get to choose what you want to listen to. And then the machine is programmed precisely based on the imaging from that morning to move. If they have to move your head, the machine does it in very, very tiny increments. So if you're not sleeping by then, in my case, I'm usually at least partially awake still, you can feel the machine moving your head a little bit to like realign it for the dosage of the gamma rays. I think the longest maybe I've potentially been needed to be gamma knifed, so to say, could be like maybe between 20 and 40 minutes. I've had 3 craniotomies, which then leaves a significant surgical site that then needs to be radiated, and that can take longer. It's like kind of like they're crop dusting with radiation that whole surgical site that they just removed the tumor from, and so the tumor's coming out as well as some brain tissue, and so then like in my case, I've got a divot in my brain basically that needs to be radiated, and that can take a little bit longer depending on how big the site is.
Wow. And I didn't realize when you said bolted that frame to your head, you actually mean they're having to attach it. Like, can you?
Yes.
So what does that mean? So when you said Novocaine, I mean, are they having to inject or just topical? What's going on? Yeah.
Yeah. Well, so it's a whole process. And the neurosurgeon is the one who does it. And assisted by the nurses who know how to do this. It involves a lot of real careful measuring. But basically, the frame goes over your head, and then they have to line it up with, as best as they can, on your head. Excuse me. So they have to look for the best places to bolt. So I'm pointing in the video here where my fingers are, right up here. This is usually where it goes on the front of your head. It's right up in here. So there's 2 bolts here, and the other 2 bolts are behind in your occipital lobe. It's kind of like where your head kind of dents down, below your skull kind of dents. It's right below that, which is there's a nerve that runs along your head right there, your skull, which is where they have to attach the other bolt. And so they're actually bolting. So first they do the Novocaine, which involves, I'm showing you here, needles that are about, 6, 8 plus inches long in order to get through the frame. They put the frame on your head first, they line it up, they see where they want to put the bolts right about here, they figure it out, and then they get the big Novocaine needles come out, and it's fast-acting Novocaine. And sometimes I've had 2 doctors, and sometimes they've done it 2 at the same time, so they're on either side of me, injecting these big Novocaine needles, first in front, and they inject the Novocaine, and it stings and it burns, and it's not very comfortable. It's pretty painful. And then they move to the back, and they do the next 2, and by the time they're done with the 2 in the back, the ones in the front you're numb by now. And so then they take tools that they actually screw into your head now, the frame. They've got tools and bolts that they then actually screw into your skull at that point. And they get out their wrenches, and they're wrenching them into your head.
Wow. Okay.
So you can hear the metal, you can hear the wrenching, you can hear them screwing.
Wow.
But by that time, if they've done it well, you can't feel it anymore.
Okay. Wow, I didn't even know that procedure existed. And so for people who are watching this video or reading your story and they're about to have their first experience, do you have any sort of words for them?
Well, for me, and for people who have asked me, kind of what's the strategy, I've had it done now so many times, I kind of know what to expect. And so if you've never been through it before, the one thing I say is it goes really fast. It'll be over very quickly. And if you can use whatever techniques that you may already have or be aware of, if you can breathe through the bolting process to get through it, it doesn't take very long. And what I do is I fixate and I look at something ahead of me. I do not close my eyes because that doesn't help me. But some people it might because then they wouldn't see the needle. But I focus on something else, and you can pretty much count on, a minute or less of sort of that intense the intensity of the bolting process, and it does subside. And then once that's done, you're really just kind of waiting to get put into the gamma knife tube, and you can kind of sleep. And then you can just go home and bandage up your head because they want you to keep those bolt sites clean. And they bandage your head. You go home. I usually go out to breakfast. I go out to breakfast with my big bandage on my head to my favorite pancake place, right?
Treat yourself, yeah.
And then, you may not really remember all of it once you nap it off. And so that's the best thing as I can say is it will go fast, it will get done. And in this case, the result of the gamma knife for brain tumors for this type of cancer is pretty effective.
Okay, and of course, that's the biggest motivator is just knowing that it's been effective. I'm looking at your timeline, and you've had to, of course, I mean, you said, how many times is the gamma knife? I mean, I'm looking at all this green.
I don't have my
yeah,
me, but I think it's about 15 times.
Wow. After all, I mean, is there anything else you want to say about that since you've had to go through it so much? Are you having to do it? I see it's almost like at a pace of twice a year that you've had it done, at least on the timeline. Was it just?
Yeah, for me, I will say that after the original surgeries that I had, which was the first brain surgery, the kidney surgery, and then that same year, that first year that I was diagnosed, I also ended up having a lung surgery. So that lung surgery was to address a couple of lung mets that were later discovered that were not behaving. Well, everything else systemically seemed to be behaving. These two lung mets weren't. And so the idea was we're going to go in, we're going to remove those lung mets, and then they won't be there anymore. And so I had these 3 surgeries in a short period of time, as well as that IL-2, as well as a gamma knife, right? All within that first year. And so what I didn't realize was that, I quickly realized, but didn't really have context for, is that for me, the most of my recurrences with this disease have been brain tumors, which meant that I was getting scanned, MRIs, brain scans, I'll say, every 3 months. So, they're looking for something if they're looking that frequently. So in that first year, or the first couple of years, I was having serial brain tumors. Like pretty much every 3 or 4 months, I would have another brain tumor, which then ended up, I needed 2 more craniotomies, which, was as a result of, a couple of tumors did not respond well, ultimately, to the gamma knife control. But yes, I would say, if I've had 15 brain tumors and I'm, close to 10 years, that kind of, you can see how often they've come. I think I had one period of time when I did not have any brain tumors for about 2 years. And currently, I have not had a brain tumor for a year and a half.
Oh, that's so wonderful. So this is your second sort of break from having to deal with the
From brain
constant.
tumors, yes.
Yeah. Are you having to undergo the MRI still quarterly, or
Yes,
you are? Is that in
every
purpose?
3 months.
Is that
That,
just ongoing?
yes.
Okay. And then
When I was originally, oh, sorry,
no, no,
I
please
was
go
going to say
ahead.
when I was originally diagnosed because of the brain tumor situation, the radiation oncologist who I've been seeing ever since then pretty much right away said, don't ever let anybody tell you that you should wait any longer than 3 months between brain MRIs. And that was a recommendation that I've tried to live by. And the point is that if they find something when it's still small, it's much easier to treat. And that path has deviated at least once for me, which didn't turn out very well. So that's another area where, as a patient, I've had to learn that even if the neurosurgeon says it's okay to wait for 4 or 5 months, and the other doctor says it's not, you as a patient have to make sense of that. And in my case, I learned kind of the hard way. And so I am now very, very committed to not waiting more than 3 months between MRIs, brain MRIs.
Okay. And the one time you waited, it was about 4 to 5 months as opposed to 3, and it had grown. Is that what happened?
Yeah, that's what can happen. I mean, as you go through your sort of cancer process, depending on, how long it takes to get it under control, or maybe you're constantly managing it. But in my case, I've been pretty much constantly managing it. Yeah, I mean, this is a situation where, one of the doctors that was monitoring me actually missed one. He didn't see it. Now that's happened to me more than once. So these tools that they're using, they're not perfect. They're good, right? Imaging is good. It's better we have imaging than no imaging, but they're not perfect. They're not infallible. And that's true with any doctor as well. As good as they may be, they're still human beings, and so there is like a margin of error. So I've had a couple cases where a brain tumor was not picked up when it could have been, which meant it gave it time to get bigger. And so hopefully by having frequent MRIs like that, the potential for a brain tumor to get out of control is reduced, but it's not zero, in my case at least. And so, if once the brain tumor gets to a point, it shouldn't be in your brain anyway. And so the potential for a brain tumor to start causing trouble cognitively or with swelling is always there. And once they apply a radiation tool, the tumor will also swell in reaction to the tissue damage. And so there's constant monitoring anyways of what the side effects might be, even from having a gamma knife. So yeah, I mean, if I'm having them done regularly at the 3-month point, ideally, if they find something, they can treat it, and if they can treat it when it's smaller, you reduce the possibility for a variety of other adverse outcomes.
Okay, I gotcha. So I understand the different treatments up until this point. How were you able to, how did you approach talking about, like different therapies, immunotherapies or drugs to take with your oncologist? What was that process like? Because I hear from before you said you and your husband would do a lot of your own research as well.
Well, my husband did the early heavy lifting. Like I said, I was pretty out of commission in terms of that kind of a thought process. So he was able to do that originally. And the oncologist who I have now is he's a researcher as well as a clinician, and so he's very knowledgeable about all of the types of new and coming and ongoing research when it comes to treating this kind of cancer. So it's really been, because I've been with him since the beginning, really the dialogue has grown. It's grown. We have become more knowledgeable. So for me, because a kidney cancer back in 2011 when I was diagnosed happened to be a type of cancer that was known to potentially respond well to immunotherapy. Immunotherapy at the time was still kind of a relatively dubious-ish kind of treatment because it had not been very fruitful for many, many years from a research standpoint. However, my oncologist was very aware of the research and the trials that were underway at the time, where they were having some new success with immunotherapy products. And so he was really instrumental in helping us understand the vocabulary, the kinds of drugs that were being tested and studied, what they did, how they operated, and how the use of these new and coming drugs would be deployed for me as needed. There was a strategy from the beginning around which things to use first and which things to reserve. And the doctor had a way of talking about it that helped us understand. We're talking about, like, what's our toolkit? What's our toolkit to fight this, right? What kinds of things do you take out first? What kinds of things do you reserve until later? Which kinds of things might interfere with each other? And so we've learned a lot as we've gone. And we've also taken it upon ourselves to follow the research as it is actually developing. So we've kind of come to the point where we can follow some of the medical science at a layperson's level, but in a way that comes to life for me because I've lived it.
Yeah, absolutely. Do you have the top pieces of learnings that you want to share? I mean, you've already described some, but to people on, especially when there's no quote standard, procedure of care or protocol, how you have to really take it into your own hands. I mean, anything you think top of mind for you here that you want to share with people?
Well, I think it helps to have an ongoing curious mind, right? That I think that there's more than one way to look at the problem, and sometimes finding more than one way takes a little longer. And so sometimes people feel very rushed and pressured to make a treatment decision right away. And sometimes that's necessary. I mean, I can't, speak for every situation, but I think that probably more often than we realize, as a patient, you should be able to have adequate time, to be given adequate time to try and really understand what's on your plate, what might be missing from your plate. And if you need to go gather more information, to do that, to find a way to do that. And kind of that top flagged, potentially good question to ask yourself is, does this doctor specialize in my particular cancer? And in my case, the answer was no. And I had to go farther. And I think that's something that we don't know when we start this process, is that not every doctor is going to have the answer. And maybe it'll be a team of doctors that work together to formulate the answer. And it might not be clear to you in the beginning, but I don't think it's ever a bad idea to give yourself some time to think through what's going on, figure out the questions that you want to ask, find another source of information. It could be looking on the internet, looking for a particular disease type, looking for particular institutions or doctors who specialize in a particular diagnosis that you may have ended up with, and ask a lot of questions. And that's the best thing I think any patient can do, is to ask a lot of questions. And if the doctor doesn't like it, which I've had, I've had that happen, then I think that's also something that as a patient you should be able to call the shots on, which isn't necessarily easy. But the other thing I would say is that your mental health as a patient, as a cancer patient, somebody who's been diagnosed with cancer, is very crucial to take care of. I can speak for myself, where, I went through at least the first 2 years after my diagnosis being, pretty depressed. And I've had, antidepressants offered to me, counseling therapy offered, and my initial reaction was, why? Are I supposed to be depressed? I have stage 4 cancer. Well, I can only say how wrong I was. Once I was able to recognize that having my mental health in as good a position as I could would only bolster what I could bring to the table for my own understanding and my own path for treatment decision making.
Wow, thank you for sharing all that. Really appreciate it. And I think that'll be very helpful for the people who are reading and watching this, for sure. And so you've described a lot of what you've gone through. I want to delve into the mental aspect of it in a little bit as we wrap the interview. But before we get there, I see that you had been in this routine of getting scans and the gamma knives procedures done. You had the 2-year period where stable scans. And then it was October of 2016 when the recurrence of disease was detected in your right kidney, liver, pancreas, and lung nodule, and also one new brain met. I can only imagine, I can't even begin to imagine really that being the news after you have these 2 years of this break. Can you walk us through how you were able to process that, what happened there?
Well, part of the way I dealt with it was a function of what I'd already been through, including like a 2 year sort of still period, right? I was still getting regularly scanned. With scans come lots of anxiety and uncertainty. So I had, by the time I'd had that recurrence that you just mentioned, I'd had now several years of dealing with what they call anxiety and dealing with the uncertainty. And in many cases, the uncertainty was unbearable. And so, you learn how to cope with that, hopefully, in the best way that you can. So even though I'd had a couple of years without any brain tumors and without any visible disease from the imaging, in my case, I had already learned that some of these imaging was infallible, which was not always as accurate as you might hope it is. So I always kind of knew that day would come. It's a part of the paranoia that you live with as a cancer patient. So when it happened, it was like going back into autopilot. It was going back into gathering information, understanding mode, sort of like the lessons that we had already sort of learned so far were part of what we dealt with this new situation, which included follow-up testing. We needed more testing. The original testing wasn't enough. We needed more testing. We needed to talk to more than one doctor. By then, my original oncologist had returned to Minneapolis, and so I could reach out to more than one specialist once again to get another opinion. And I will say once again, the original reaction to what to do in the case of the recurrence in my remaining tumor was surgery. Let's go in and get it out. And I thought, I'm not sure I like that idea because I only have one kidney left. And so getting yet another opinion, which was a return to my oncologist who had just come back to town, which was fortunate. And the answer he gave was different. It was, I think we should not do surgery right away. If we have to do surgery, okay. But, even in the best of cases, you only have one kidney left. And even in the best of situations, surgery is hard on the body and things can go wrong. And so that was, again, we deployed our process, which we had been learning all along, which was to ask many, many questions, figure out what possible options are available, and make the best choice that I could at the time. And so there's really by then we had learned many lessons to deploy, which was chiefly gather the information, make sure you understand what you're seeing, look at the records, look at the reports, read them, ask questions. Don't necessarily go with the first recommendation until you understand, in our case, what the variables were.
Okay. Yeah, that's sound advice. And it looks like here you did try the radiation, but it wasn't effective. So you went on a couple different treatments. And I don't know, Opdivo looks like it was pretty successful for you. Is that true? Or,
Yeah.
Go ahead.
So at that time, this was really the first instance where I had spread of the disease discovered in my other organs, other than in my lung and in my kidney, which was now gone, my left kidney. So this was a new frontier for me, being that it wasn't my brain this time. And so what we tried was first the body radiation, which is like gamma knife to the body. It's not necessarily as effective, but it's a potential option. And that's what we tried first, to see if we could contain that kidney tumor with radiation. It didn't work, and so the next step was to try two things. And this was like in 2016, maybe by early 2017. I don't have my timeline in front of me, but the point is that once we knew the radiation didn't work, the next thing we tried, we knew that we wanted to get me onto the nivolumab, which is also known as Opdivo. That's the trade name. And it's a type of immunotherapy. However, the kidney tumor at the time was big enough that it was starting to encroach on one of my ureters. And so there was a need to shrink that tumor if we could, as quickly as we could, before putting me on the nivolumab, the immunotherapy, because the immunotherapy doesn't necessarily work that fast. So what that meant was I had access to two drugs that had recently been approved by the FDA within months, literally a handful of months before I needed them. I started taking something called Cabometyx or cabozantinib, which is not an immunotherapy. It's a different kind of a drug that operates to basically, cut off the blood supply, sort of high level, it's like cutting off the blood supply basically to that tumor. And then the idea was to keep me on that as long as I could so that I could get the most benefit out of that particular treatment, and then switch me to the immunotherapy, the nivolumab, for longer term maintenance. And so that's exactly what I did. I was on the cabozantinib, which was released within a couple of months of my being able to use it. And I was on it for less than a month before the side effects sort of, got me kicked off of it, because they were, can have some harsh side effects.
What were they?
And well, for me, so because it was recently released drug, I was already on a high blood pressure medication. That can be manageable. The thing that ended up tanking my experience the first time involved like eventually uncontrolled diarrhea, nausea, and vomiting. And when you can't control those three things, and like other kind of like significant GI symptoms that were not able to be controlled by other kinds of medications. And so I was on that particular drug for less than a month before the decision was made to get me off of it and put me on the nivolumab. And so that was the decision we made. But even after having been on that problematic, that first drug, for less than a month, the kidney tumor had already shrunk significantly. And so it was no longer like encroaching on my ureter or causing any more like problems like that. And so then once I went on to the nivolumab, I think so it was kind of like a 1-2 punch. The nivolumab then I was on for about 8 months in different courses. First it was like once every 2 weeks, and then it was once a month, and then I went to once every 5 weeks. But after about 8 months of constant monitoring, all of the visible cancer that they had been looking at in my abdominal cavity, including the kidney tumor, were gone.
Wow. Amazing.
And that also the nivolumab was also had been a really recently released drug for me to be able to take advantage of those, kind of just in time almost medications.
Wow, that's incredible. And the nivolumab, did that have side effects as well, or were they pretty manageable?
For me, I haven't really had a lot of side effects. The only thing that I've experienced, which is pretty unique, I think, but it can happen, is I've had hives. So I go to the cancer center to have the nivolumab infused. So they have to set me up with an IV, and then they infuse it over like a half hour or something. So what would happen is after I'd been on it for many, many cycles, I started to get like a stray hive here and there. Like I got one on my neck. And everyone was like, oh, well that's weird. But it happened 2 or 3 times. And and of course the concern is with an immunotherapy, because it's potential to like cause an overreaction in the immune system. And hives and anaphylaxis, right, like an allergic reaction, could be very serious. And so they would treat me in the chair when those hives showed up with intravenous Benadryl kind of thing, right? And so I would get kind of dopey from the intravenous Benadryl. So that happened 2 or 3 times. And now what they do is they pre-treat me with oral Benadryl. So I get there, I get my IV hooked up, they do all the testing, the blood tests and everything, they're monitoring. And then they give me the Benadryl, oral Benadryl to kick in for like 20 minutes. And by then, sometimes my medicine's there, and then they hang it up. So that's how for me, that's been the only side effect that I've had, which is very manageable.
Okay, that's great news. I know that was a few years ago in terms of when you had access to the nivolumab, but maybe the higher level question for people who are interested in access to the latest treatments is, how did you get access to it? Were there insurance hoops to jump over or jump through? And was it your doctor who helped? I mean, how did you get that done?
Well, my current oncologist, who I've had throughout all of my significant treatment, he has the prescribing authority. He's very knowledgeable about all of these drugs, which again goes to one of my earlier points, which was know who your doctor is and what they know how to do. And so this particular oncologist has such a deep knowledge of clinical, not only in the clinic, but also with trial studies. He's been the head of more than one clinical trial program, so he's very knowledgeable, and he's got far-flung contacts, professional contacts that help inform him. He's just deeply involved in that side of the practice, and so he's very knowledgeable. So when it came to understanding these options, it was not only sort of him helping us understand like the treatment, kind of the what these various treatments would do, but access to them. And so I've also had very good medical insurance, health insurance, and I've never really encountered a problem with either rejecting or having extraordinarily high costs associated with my health care at this point. I think that could always change, there's some uncertainty, I think, to some degree about where healthcare and health insurance is headed. But that's, I think, another significant component for me has been my very stable and available health insurance. I've never had a problem with it. I do know that for people who are unable to get coverage, or the coverage is, even with insurance, is too expensive for them, the copays, these pharmaceutical companies apparently have programs to help assist patients in paying for their treatment. I've never had to invoke that, but there have been times where it's been put on the table.
Gotcha. Okay, and that's a great tip, a resource people to look at in case that's a problem for them. I'm wrapping up the interview now, and Laura, thank you so much for spending so much time sharing all of this. So I see that you did have some more mets, through the years, and so you had to restart the nivolumab, also Avastin. Is there anything else you want to say about the ongoing treatment for you? Any advice for others, or anything you want to share?
Well, I mean, outside of the fundamental hope that, a patient can find the right oncologist or oncologist team, a team of doctors approach, which is what I've needed in my case, I think is that, being able to and willing to do your own due diligence and participate actively in the treatment decisions, so that, you can be as empowered as possible with what's happening to you. And then what me and my husband have really learned over the years is, for me, in my treatment, it's really been ongoing with a couple of breaks. But we've pretty early on realized that this was not a cancer that was going to go into remission exactly. So facing a series of treatment decisions, options and decisions, has really been, on the emotional side, which I think is critical to be aware of, as much as it's, hard, and it's like running a marathon in a lot of ways to continue this type of lifestyle. Every new situation that requires some kind of intervention, whether it's a new brain tumor or a recurring met somewhere else, something that we thought was put to bed and then it comes back. What we have strived to be able to say to ourselves is, well, let's see what we do next. What do we do now? And let's marshal our evidence and marshal our resources and take the next step.
I love that, because you're approaching this as you just have to look at it day by day, it sounds like, or just to keep moving forward. I mean, do you find that you can't look too far ahead, or you can't go to the back, can't look too far ahead? I mean, what's the approach there? I know people handle it differently.
Well, I think that whenever there's a potential mortality staring you in the face, it does sort of sharpen your view of the present. And for a long time, that was all I could hang on to, was the day today. I had a hard time looking too far ahead in my calendar and scheduling appointments. You know, but at some point, you know, there's a balance. There's a balance that for us, we started to realize, you know, everybody has a mortality. You know, there's a clock on everyone. That's the way it works, and we just know that mine is ticking really loud. So it becomes more of a balance, you know, remembering that we're here today. Tomorrow is never guaranteed for anybody, and what do you want to make of that, and how does your experience help you actually see life in a different way? So I've been dealing with this for almost 10 years, and my child was just turned 7 on the day of my first brain surgery. And he is now 16 going on 17. Wow. And we're teaching him how to drive. And we're stuck inside with COVID-19 restrictions.
Right. Oh my gosh.
And so I think the takeaway in some ways is to try and find a balance, because nobody can predict what's going to happen to you. Nobody. And the statistics may tell you one thing. I can tell you, when I was first diagnosed, I gave every doctor who came into my room to meet with me an advisory that I don't want to hear any statistics. Because I knew they weren't good.
Yeah.
They were not good. They were single digits for me to be alive in 5 years. And I knew that. I knew that it couldn't be good. But that was how I controlled it. I did not want to be reduced to a statistic. And I think that there's something very empowering about that people can think for themselves, that nobody knows what your path is going to be. And I'm a really, really good example of that. And nobody expected me to still be alive today, except maybe my husband.
He's like, you're not going anywhere.
But there's a message there. There's a really important message there, which means to me, no matter really what somebody tells you is going to happen to you, nobody really knows. And you can hang on to that in a positive way. And you can go forward, you can look forward and stay present, and look backwards sometimes. And in my case, looking backwards has had the benefit of helping others. So I think that's also a very valuable thing to bring to the table for yourself.
Yeah, it sounds like you've found a purpose in this. You've helped so many people one-on-one, and now with, I'm sure through just your voice alone. I actually had forgotten to ask you, because you had alluded to the scanxiety, which is so real for so many people, but especially for someone in your position who's had to go through it so much. It sounds like, you know, is it still there? I mean, how have you, you know, dealt with the scanxiety?
Well, that was a process. And I do think that people develop their own strategies. Everybody's different. I for whatever reason, have been able to compartmentalize it. It wasn't that way at first. Because the upcoming scan would always mean another opportunity to find more disease, which of course is the scanxiety part of it. And so for me, with time, I just learned, you know, over the course of extraordinarily emotionally painful experience, that I had to be able to exist, I had to coexist with some of these almost unimaginable kinds of frightening things out there that I couldn't control. So in my case, I think I just learned to compartmentalize it, because it was almost impossible to exist on a day-to-day basis if I was so worried about the next scan all the time. So what that means is, by now, I don't really get scanxiety anymore. I will will get most anxious waiting for the doctor to come in the room to tell me what the results are. So I've reduced the timeline to sitting in the waiting room, and that's what works for me. I know my husband has a very different experience because he's a different person, and he's also not the patient. He's got a very different perspective, and so he still struggles with this anxiety, and we just have very different ways of coping. But for me, that was it. I had to make a proactive decision that it was too difficult for me to live in that emotional upset on such a continuing basis. I had to like flip the switch basically for my brain.
Gotcha. Laura, you've shared everything under the sun with us. Is there anything that you feel you haven't been able to share that you'd like to get out there?
I don't think so. I think at some level we probably touched on everything. Finding it somewhere inside of you to get back up. If you can, get back up every day, do something that you can put one foot in front of the other, even if you're still recovering from surgery or something. Find whatever that is, that place within you that allows you to pick up your head and face the next day. And that's kind of a big thing, but it's an important thing, and I think that's what I've learned.
I love that. Thank you so much, Laura, for spending all this time with us and sharing your story.
You're welcome. Thank you for asking. It's a long sordid story, but if it can help anybody, then it's worth it, right?
I have no doubt that it will. So